All right, let's talk about pneumonia. There was a big update in 2019. A lot of this got pushed into the cupboards and under the counters because guess what happened is that's when COVID occurred. And really people weren't paying much attention to bacterial pneumonia at that time. It was more COVID-19. So what is pneumonia? Is lung inflammation caused by bacterial or viral infection, in both which the air sacs filled with pus become solid. Inflammation may affect both lungs. You have the famous double pneumonia, or one lung pneumonia, single pneumonia, or certain lobes, lobar pneumonia. Pneumonitis is typically used for when it causes non-infectious agents such as, how about aspiration, chemical radiation, pneumonitis. Community-acquired pneumonia diagnostic. Let's get first you need to have a chest x-ray showing a new infiltrate in at least 2 of the 4. Fever, cough, dyspnea, chest pain. Prior, we needed non-hospitalized for at least 2 weeks, for at least past 2 weeks. Now, prior age gap was getting HD, being in a nursing home, recent antibiotics and chemotherapy in the last 30 days, hospitalizations last 2 days within the last 90 days. It went away. And HCAP is out, and now they have HAP, which is greater than 48 hours, and VAP greater than 48 hours on the VAP remain. Okay, HAP is hospital associated. You've been in the hospital for 48 hours. HCAP was out. The reason why they took HCAP out is because of there was a lot of triple coverage, and they wanted double coverage for Pseudomonas. So the Infectious Disease Society was worried is we're going to get a lot of resistance because a lot of people fell into the HCAP area, and what was happening is they're getting a lot of antibiotic exposure, and it was concern for resistance. And I'd like to bring a big study that came up in October 14, 2023. And it was called the ACORN study, and it was cefalpine versus piperacillin tazobactam. And before that, there was another study that said, you know what, piperacillin tazobactam with vancomycin, there's a signal that it's going to cause injury to the kidneys. And this study was kind of pushed as dogma. In fact, a lot of the large EMRs, what they were doing is if you clicked on an order with vancomycin and you had piperacillin tazobactam, you got a warning that said, hey, this is increased risk of kidney injury. Now, this was probably an overreaction because if you actually read the study, the author says we need more studies. This is a signal we need more studies. So then the ACORN study came later and said, you know what? Tazobactam versus cefalpine is cefalpine can cause more confusion, more altered mental status, especially in older patients, especially in patients with acute kidney injury. Because cefalpine appears to affect the GABA receptor like the other beta-lactams, but a little bit more. And what can happen is you can have an increased risk for non-convulsive seizures. So now the studies, the further data in the ACORN study, which was well done study, shows that piperacillin tazobactam is probably safer with vancomycin, is safer than cefalpine. Now there's been some other subsequent studies, and I think there's a lot of wars between the cefalpine and piperacillin tazobactam group, but I think overall is we're starting to see more piperacillin tazobactam and less cefalpine use, especially in older patients, especially patients with acute kidney injury or patients who are prone to seizures or patients who are coming in altered mental status. And we'll talk more about non-convulsive seizures. We do that in the neuro section, but something I want you to think about, if you have a patient that comes in normal, you place them on a medication like cefalpine or a fluoroquinolone, and now we have altered mental status. Could this be hospital-related delirium, or could it be a medication side effect? So let's talk about severe CAP, where you have 1 major or greater than 3 minor criteria. Major criteria is mechanical ventilation, so this is for severe CAP, or septic shock. Minor can be confusion, hypotension, hypothermia, that's a temperature less than 36 degrees Celsius, and PaO2, FiO2 ratio less than 250. And the PaO2, where do we get that from? We get that from arterial blood gas, and then the FaO2 is what the amount of oxygen that we're giving the patient. Multi-lobar infiltrates, and BUN greater than 20. White blood count less than 4. Thrombocytopenia less than 100,000. This would be criteria to meet severe cap. And why is this important? We'll discuss why we're talking that severe cap is important as a diagnosis. Continue discussion on cap, diagnostic, blood cultures, severe cap, empirically treat for MRSA, or the question is Pseudomonas. And if they have a history of MRSA, Pseudomonas, recent hospitalization, antibiotic use within the last 90 days, there would be a question of getting a urine pneumococcal antigen or urine Legionella antigen, influenza testing during periods of high influenza activity. Procalcitonin, not recommended. You're saying, what? We do that all the time. In fact, some of it may be on your order set. Now, procalcitonin, there's different things it can be used for. Originally, kind of the discussion was to distinguish viral from bacterial pneumonia. The sensitivity was 55% in these studies, and specificity is 76%. So procalcitonin really hasn't done well in those categories. Procalcitonin can be used, though, as people are using it as to kind of work on when we discontinue antibiotics or when we should stop antibiotics is more what procalcitonin is looking like is better use for in the studies. What's a patient that we would be concerned for? What are some things that we want to be concerned on these patients if we have severe cap? If fever over 38.3, intravenous drug use. If they have rigors, some parts of the country call them rigors, okay? And these are these uncontrolled shakes. What do we worry about when we see that? This is an old school thing. This is an old school worry where the old providers would go, oh my gosh, we see this, this is a bad thing. Rigors is where they have these uncontrolled shakes. We worry about bacteremia at that time. What if they have comorbidities such as bone marrow, recent bone marrow transplant? So these are things we would concern about for severe cap. Now, this is a study that comes out at hydrocortisone and severe community-acquired pneumonia. Now, ICU for severe community-acquired pneumonia, bacterial pneumonia, recommending getting IV hydrocortisone 200 milligrams, usually scheduled 50 Q6, 50 milligrams Q6 for 4 to 7 days, followed by taper for a total of 8 or 14 days. And this is the primary outcome was death at 28 days. The severity of pneumonia was defined by presence of at least one of the 4 criteria: mechanical ventilation with a positive end expiratory pressure of at least 5 centimeters of water, initiation of oxygen therapy through high flow nasal cannula. We can also call these possibly heated high flow with a ratio of partial pressure of oxygen to the inspired fraction of oxygen, which we talked about, the PaO2, FaO2 less than 300 with an FaO2 of at least 50. And for patients wearing a non-rebreather mask and an estimated FiO2 of less than 300. So giving the steroids had a lower risk of death at 28 days, less intubations. This is an important thing. This is very important. Less patients were started on pressors. This was kind of a landmark, groundbreaking study. So before, it was kind of a question of whether to give steroids for pneumonia. There was a question of when to initiate them, and also the question of what types of pneumonia. It appears the studies have kind of gone back and forth for community-acquired pneumonia, but for severe community-acquired pneumonia, the steroids should be initiated. And this question has come up more and more: is pneumonia duration of therapy? Why is this important? Well, first of all, is antibiotics themselves can cause harm. And plus, the longer the patient is in the hospital, there's higher costs and increased risk of further injury to this patient. They're not in their home environment, there's increased risk of injury. So what are some things? The duration of therapy recommending right now is 5 days. And once patients achieve clinical stability, 48 to 72 hours, stopping the therapy. So 5 days after patients achieve clinical stability within 48 to 72 hours after therapy. So what this is saying is that the patient, if after the patient has received stability, 48 to 72 hours after starting the therapy, what does that mean is that the patient has gotten better within 48 to 72 hours after initiating the therapy. If they're not, we need to realize that maybe the diagnosis is not correct. We have some sort of other error. There's even studies going on of just initiating antibiotics for 1 day. We'll see how this pans out. The duration of therapy for antibiotics, you're starting to see more and more literature on this. Before it was literally based on the calendar. Some people got together and said, well, 7 days would be good, it's a week. I feel that 2 weeks for severe pneumonia. We're starting to see more tailorization of antibiotic therapy based on studies that are coming up and are reducing the total amount of antibiotics given to the patient. For CAP proven MRSA or Pseudomonas, 7 days is what's recommended. So remember, in the 5 days is the patient has achieved stability within 48 hours after initiating the therapy, or 72 hours after initiating the therapy. If not, we have to consider maybe we have the wrong drug we're treating, we don't have proper coverage, or we have a wrong diagnosis. Follow-up chest imaging is not recommended. We've kind of talked about this before. Post-treatment chest x-ray is not indicated because the results will not immediately change and can linger for 2 to 3 months post-treatment because it takes time for those neutrophils to get there and then the macrophages. It takes time for that to clear. Secondary symptoms of cough, fatigue, and other symptoms can persist for days after complications of medications. This can be a problem because people will say, well, I'm not better, so they go to their PCP after coming from the hospital, or go back to their PCP if they're being treated as an outpatient and get other rounds of antibiotics. What is this happens is we can have side effects from antibiotics that we should not be getting. Symptoms without continued fevers does not mandate extended course of therapy. What we're trying to do is reduce the total amount of antibiotics given to an individual because of the side effects of the antibiotics. You're saying, what are the big side effects? We're going to talk more and more about this, but I want you to start thinking about the gut biome. There's even a biome in our lungs, and this is a natural protection, a natural source of, say, this is their neighborhood. Their gut is their neighborhood, and there's good and bad neighbors. And what we're trying to do is keep the good neighbors and get rid of the bad neighbors. And I really want you to think that there's a lung biome, and I want you to think of there's a GI biome, and that by giving antibiotics, we're destroying these neighborhoods, and we allow bad neighbors to come in, and they can hurt or even kill us. Pneumonia for CMS. What is required for pneumonia for CMS? First thing needs to do, these two things need to be done within 30 minutes of the patient arriving. Very easy. Getting a pulse ox, so this should be done right away in the ER. This is an assessment if a patient is in a good or bad hospital. Cannot go home if hypoxic, hypotensive, or confused. That makes sense. So as soon as they come in, they need to get a pulse ox. Okay, this makes you a good or bad hospital. This is what the CMS is going to assess you on, and then you need to give antibiotics. Now, could this be controversial? Yes, because the fact is maybe we're giving antibiotics on patients who don't need them, but the providers are so rushed to make an assessment and call this pneumonia that they give these antibiotics right away. Chest X-ray is done. Estimate the severity is not based off the chest x-ray. One lobe of pneumococcal pneumonia can kill you. Viral and mycobacterium can have all 5 lobes and not kill you. So when you say, oh, we got the double pneumonia, yes, it can be bad, but just one lobe of pneumococcal pneumonia can kill you, and viral pneumonia with all 5 lobes, somebody may feel like they're going to die, but they're less likely to have mortality. The most specific test for the organism is sputum stain and culture. As this moves on, as we get PCR, all this is going to change. Now let's go back to our original case study here, and we're talking about this patient. And why is this patient important? Because this patient went through a lot of things. Remember, they're a 56-year-old male. They were a telecommunications engineer, meaning they worked on cell towers. They went around the world, but lastly, they've been stationed in Argentina and been eating on the economy. So they received the fluoroquinolone, and now they're noted for loose stools.
what do we have to worry about in loose stools? Especially on someone who's received antibiotics. We have to worry about C. difficile. So C. difficile, the treatment has been changing, and there's been groundbreaking as far as diagnosis is the PCR of the stool. It's rapid, it gives sensitivity and rapid test. And there's also a problem with it is probably a lot of percentage of people are carrying the C. diff and it become positive. We're carrying it in our balls, but it's under control. It's under control. I guarantee you as a healthcare worker, probably more than likely have a propensity for carrying C. difficile and would have a positive C. diff PCR, even though you're not having an active C. diff infection. Those spores are very resilient. In fact, there's been studies of going, those stations that you have outside the room that are used to, gowned up when patients have C. diff. Those stations are filled with spores, and those spores can survive a lot. Sometimes those spores can even survive those bleach wipe downs that you get, and you're probably taking them home, and you probably have C. diff spores in your house. No matter how active you are trying to keep your house clean and keep your hands washed and keep everything clean, it still would be a percentage chances that you have C. diff spores at home. So the testing is better, but maybe now it's too sensitive. Before we used to use the toxin A and B, it's not used much anymore, but now we've gone more to the C. diff PCR. So the most accurate diagnostic test for C. diff is the C. diff PCR. What do we worry about when we have C. diff? What is the big thing we worry about? Yes, they can have hypotension, shock, severe electrolyte disturbances because you're pooping out so much. The C. diff worsens, you can get megacolon, and megacolon could be deadly. It's basically a severe infection. We have distension of this colon, and you can have perforation and leads to death. C. difficile treatment. Now, we're going to talk about boards, what they're going to recommend versus the real world. And what's the big difference? It's going to be money. Unfortunately, it's going to be money. For non-severe disease, where the white blood count is less than or equal to 15, and creatinine less than 1.5, vancomycin PO 125 milligrams 4 times a day, or fidaxomicin 200 milligrams PO 2 times daily for 10 days. If unavailable, metronidazole, and metronidazole is nowhere near as good. You may even have to transfer somebody if for some reason you do not have vancomycin, because metronidazole is just not going to do as good a job. 500 milligrams PO 3 times a day for 10 days. Severe disease, white blood count greater or equal to 15 and creatinine greater than 1.5. Vancomycin PO 125 milligrams 4 times a day, or fidaxomicin 200 milligrams PO 2 times daily, Q10 days. Fulminant disease is where you have shock, ileus, or concerns for megacolon. This is where you're going to get vancomycin is going to be 500 milligrams PO. If you can't, if there's an ileus, you give it rectal 6 times a day with metronidazole, 500 milligrams IV Q 6 hours. Why are you giving the metronidazole? The metronidazole is hopefully to prevent an ileus. Now, let's talk about vancomycin PO. First of all, let's talk about for boards. If there's a question stem that says fidaxomicin, more than likely that is going to be the correct answer. Now, will you use that in the real world as much? Probably not, because it costs so much. Some places limit fidaxomicin only to ID doctors to prescribe it because the cost is so much to vancomycin. Vancomycin, you can literally buy a bucket of it for a few dollars. The fidaxomicin is very expensive in comparison. So in the real world, you're probably going to be limited more to oral vancomycin. It may require an ID consult, depending on the facility you're working at. And so let's go back. When you take oral vancomycin, that's pretty much going to stay within the gut. Okay? Just like when you use IV vancomycin, it's not going to penetrate the gut. So IV vancomycin is not used for C. difficile. I know that, and you see learners making this mistake, and I see attendings make this mistake, is they feel that giving IV vancomycin will penetrate and get into the gut when it really won't. Metronidazole IV, it gets some penetration, but it's more used to prevent the ileus from forming. This is in severe cases. And there's discussion if metronidazole, if it even should be used. There's different camps that say it shouldn't be used. We're still we haven't reached our full apex in treatment for C. difficile. There's a lot of unanswered questions. There's even discussion of having a vaccine. Using the fecal transplant, that is going up and down, and we'll have discussions on that. We can say is that we don't know enough to say that it's going to work well. Sometimes this is the FDA has halted because there's been harm with fecal transplants. Let's talk briefly on how important, or the crazy world of the gut biome is. There's been cases, and these are mouse studies, which is very interesting, is there's been cases where mice themselves, they're determined to be depressed mice. How are they determined they were depressed? I have no idea. And these mice were depressed, and they took antibiotics that specifically carried and cleared the gut biome. There are antibiotics that just stayed in the gut, and they inoculated the biome of the gut. The depression went away. And then they took the antibiotics away, and the gut biome grew back, and the depression came back. Very interesting when you think about it, because we receive our biome from our mother, and guess what? Depression is carried down using material from our mother. So as far as there's a genetic link from that, is it the gut biome? It's quite possible. These are questions and things to think about. We really don't know much about the gut biome. This is things that we'll discuss in these lectures, but giving different pro-antibiotics and drinking the drinks with the microbes in, it may not be the right answer because we know so little about this. All right, so remember for boards, fidaxomicin over vancomycin. All right, so this patient, this 56-year-old telecommunications engineer, he has a code, okay? And I discussed this briefly. And after the code, so he goes and he gets his fluoroquinolone. He comes in for pneumonia, gets his fluoroquinolone. He's doing okay. He's eating his turkey sandwich. Before I could reach the first floor from the 13th floor where he was at, he has a code. It was a quick PEA arrest. And after the code, they started to work on what's going on with this patient. So they did a full CT scan because he's intubated and no one really is understanding what's going on. He comes in for pneumonia. It was a lobar pneumonia. It was severe enough, but it wasn't severe enough to put him in the ICU. Then he has a code. He gets intubated during the code, and then he has some imaging. And he's noted for right upper quadrant abdominal pain and abscess on the liver ultrasound. Okay, how did they know he had pain? Is they're ultrasounding, and he wasn't fully sedated, and they can see him grimacing while he's on the ventilator. So while he has the liver ultrasound, then it comes back and they get more CT imaging, and he ends up having amoebic liver abscess.